Hi, very good morning. I'm Dr. Janak Patel. Today I'll be talking on one of the very interesting topic, how you approach to a person of hypertension. So before we start, I would like to say that I am a general physician. I'm not a cardiologist, but whatever I know, I'll try to make it as simple as possible. So approach to hypertension, you know very well. To detect an hypertension, it is very easy. But good number of time will show you one slide where you can see that almost 50% of the people who are hypertensive are not detected. So we should make a very good attempt to identify the person who is suffering from hypertension, and that will be possible if you suspect a person is having hypertension and you make a proper diagnosis by taking a good blood pressure recording. Now we know that this is deadly. Why it is deadly? Because hypertension produces lot of complications, and when it is not detected, not treated, the complications incidents are more, which will have a high mortality and morbidity. You know, all these persons, they are also deadly. These are all deadly for India. So we should try to identify. So sorry, here R is missing. So there are other deadly materials also, like we call hyperlipidemia and diabetes. So we call deadly trio. So that particular thing, if you identify them early, you will be able to give a very good result. It will reduce mortality as well as morbidity. There are a lot of guidelines which are being there, including even Indian Heart Association guidelines. But all those guidelines are to guide you, and you have to treat the patient as a whole, not the figures. Yes, we always say Mera Bharat Mahan, because in spite of all this, still India is doing well. Now you know these two famous people. They give a very nice speech. So my speech may not be like these two people. But at the same time, it is not like these people also. My speech will not be like any one of this. I'll try to make it as interesting as possible. I'll talk facts of what is there in hypertension, how you do, how you approach, etc. But not like these people who does not talk what is the facts. We'll be talking on introduction, classification, management, and complications. Now, you say a person is hypertensive when there is a persistent elevation of resting arterial blood pressure more than 140 by 90. Not on a single reading, on 3 separate occasions. This is very important. Blood pressure has to be more than 140 by 90, and it has to be on 3 separate occasions, not 5-10 minutes interval. So it has to be persistent elevation, and it has to be on a 3 separate occasions and more than 140 by 90. Now there are some terminology which we utilize. I'll be going one by one. Primary means when the etiology of this hypertension, if I cannot identify by all possible investigation, I'll say that as a primary or idiopathy. But atherosclerosis is one of the cause for that primary hypertension. While secondary means there is some definite cause for hypertension. Say for example, renal, endocrine, arterial disease during pregnancy, etc. So those are called secondary. We'll be talking separately of all those conditions also. There is one another term called as a resistant hypertension. This is only on treatment. So when you give a treatment, and in treatment there are 3 minimum drugs which you have given in a full therapeutic dose, and one of those 3 is diuretic. In spite of using all in optimum doses, including diuretics, and person is still having hypertension, persistent hypertension, we'll call that as a resistant hypertension. If only systolic is elevated, diastolic is normal, say as for example 190 by 70, we call that as isolated systolic hypertension. If only diastolic is elevated, systolic is normal, 130 by 90, 130 by 100, it is isolated diastolic hypertension. Isolated systolic hypertension is very common in old individual with atherosclerosis, while in a young individual who has got marked arterial resistance, they have got isolated diastolic hypertension. When both are elevated, systolic as well as diastolic, they call it a systolic diastolic hypertension. But this particular terminology is nowadays not utilized. Only we utilize isolated systolic hypertension. Now suppose if the blood pressure is elevated so high where it gives rise to possibility of producing damage to the target organs, or already person is having a symptoms of target organ damage, we call that as a hypertensive crisis. Now if a person has got symptoms and signs suggestive of a involvement of target organs, we call that as a hypertensive emergency. And if there are no symptom signs but he is having a tendency or a threat that there may be a damage to the target organ, we call that as urgency. Both together, if you are not able to clearly identify, we call that as a crisis. There is one another terminology we utilize: white coat hypertension, mask hypertension, and much. White coat means when the person goes to a clinic for measurement of blood pressure. Blood pressure recorded on a clinic blood pressure monitoring is high. And when he goes to home, in a home blood pressure monitoring, it is normal. This is probably because of anxiety or what we call as excitement, and that produces white coat hypertension. This may not require any treatment, and if you convince the person, give a little psychotherapy, mental relaxation exercise, person may not need any one of those treatment for hypertension. While a mask hypertension means when the person goes to a clinic, blood pressure recorded is normal. In a home blood pressure monitoring or in an ambulatory blood pressure monitoring, you record a blood pressure quite frequently in the early morning, it is high. This is called mask hypertension. These particular people are not detected very commonly, and they can end up with a morbidity as well as mortality, and this person has to be treated. Sorry. Much means a mask hypertension when it is uncontrolled. Mask, U for un, C for controlled. Mask uncontrolled hypertension is called as a mask uncontrolled hypertension. It is in short form called as a much. Depending upon the blood pressure recording, all this will be possible: mask hypertension, much, white coat hypertension, labile, stable, unstable, accelerated, if you do what we call as an ambulatory blood pressure monitoring. What is there in the ambulatory blood pressure monitoring? You put an instrument at the belt and it goes on recording your blood pressure for 24 hours. So it records multiple recording continuously whenever you are at sleep or you are working or you are ambulatory, it goes on recording your blood pressure. So if out of 10 recordings, say 7 or 8 are normal, occasionally 1 or 2 are elevated, then you call that as labile hypertension. So almost 80 to 90% records are normal, and occasionally 1 or 2 records are elevated, we call labile. All blood pressure are same and all are elevated, say 140 by 90, 140 by 90, 140 by 90, we call that as a stable. All are elevated, but they go on fluctuating. All are more than 140 by 90, 140 by 90, 150 by 100, 160 by 100, 140 by 90. It is fluctuating, it is not stable, then we call that as unstable. But say blood pressure goes on rising, 140 by 90, 150 by 100, 160 by 100, 170 by 110, 180 by 120, 190 by 130. So that is called accelerated hypertension. So these are some of the terms which are very commonly being utilized. There is something called as a pseudo hypertension and pseudo resistant hypertension. Now pseudo hypertension and pseudo resistant hypertension we usually create, it is created by a nurse or by a person who is measuring a blood pressure. It is because of the false recording of a blood pressure. As well as good number of time it is by a faulty instruments also. So that is called pseudo resistant hypertension or pseudo hypertension. When you record properly, your instrument is good, your method of recording is good, we call it a true hypertension. There is also one term utilized is apparent hypertension. You feel he is hypertensive, but he may not be hypertensive. Now, according to the figure and latest guidelines, there are three common words utilized. Elevated hypertension, grade 1, grade 2. Elevated means 135 by 85 is called as elevated hypertension. 140/90 is called as a grade 1 and more than 160/100 is called as grade 2. There were previous figures which were utilized in what we call as different guidelines which were there. Now those particular are being replaced by latest guidelines. There are Indian guidelines also. Indian guidelines also divides into only three. Elevated hypertension, grade 1, grade 2. Grade 1, grade 2. This is if a blood pressure record, what you record during systole of cardiac cycle, we call systolic blood pressure. If you are recording a blood pressure during a diastolic period of a cardiac cycle, it is called diastolic blood pressure. And mean arterial pressure means systolic plus twice diastolic blood pressure divided by 3. So that will give you a mean arterial pressure. And if you put a catheter in an artery and record a blood pressure at that level, it is called as a mean aortic pressure. So if you put the catheter in a pulmonary artery, it will be a mean pulmonary arterial pressure. So depending upon that, you use a terminology. Now this is one which we usually follow. If in office you record a blood pressure and systolic is more than 140, diastolic more than 90, we call as a hypertensive. In an ambulatory recording during a daytime, if you record 135 by 85, he is labeled as hypertensive. In a night time, in an ambulatory blood pressure monitoring, 120 by 70 will be considered as hypertensive. And mean blood pressure, 130 by 80 is also considered as hypertensive. In a home blood pressure monitoring, 135 by 85 is considered as hypertensive. So these are the figures which are being utilized for labeling a person to be hypertensive. But by and large, we say that any time if it is more than 140 by 90, the person is labeled as hypertension. But it should be in 3 separate occasions. This is what we call as a home blood pressure monitoring, daytime monitoring, nighttime monitoring, and 24 hours average recording. So stage 1 in ambulatory blood pressure monitoring, 125 by 75, and stage 2, 130 by 80. And some people label this as a stage 2, and 140 by 90 is labeled as stage 1. So depending upon which guidelines you are following, you can follow according to that. But there are certain targets which are being there. 140 by 90 is considered as definitely hypertensive, whether it is having a high cardiovascular risk factor or low cardiovascular risk factor. High means more than 10%, low means less than 10%. Or age more than 65 to 80 or more than 80. Any one of this group, you require a target to be less than 130 by 80. So basic, you may follow whatever criteria you follow. But if a person is diabetic, it has to be less than 130 by 80. If a person has got severe stroke, it has to be 130 by 80. CKD also 130 by 80. In a coronary artery disease called ischemic heart disease, 120 by 80. And in a heart failure again, 120 by 80. So basically your target should be 130/80, and in case of ischemic heart disease and a failure, it should be less than 120/80. So these are the target goals. This is another slide which shows you what should be your blood pressure threshold and what should be your goal. In which person, whatever was given before, same thing is mentioned here. So try to maintain this target. These are the goal. So you bring down to this particular level. Now, the commonest causes of resistant hypertension is one, very common in India is because of high sodium intake. We call S, sodium, steroid. Where is that steroid? And NSAID. Yes, also sometimes oral contraceptive pills also can add what we call as resistant hypertension. So steroid, NSAID, oral contraceptive pills and sodium becomes very high risk for producing resistant hypertension. Now, whenever you are giving an diuretic therapy, if it is given in a subtherapeutic dose, it is also one of the factors which can produce resistant hypertension. Excess of alcohol intake. There are some drugs which are available on OTC counter, particularly herbal preparation. Good number of time Ayurvedic and herbal preparation, they contain steroids. So that can also end up with resistant hypertension. If a person is having secondary cause and you are not diagnosed and you are treating as a primary, then also person can end up with a resistant hypertension. Good number of time on the side of the patient, he is not adherent to the treatment, he goes on changing the dose, he decreases the dose, he stops the medicine in between, etc. can also produce white coat hypertension, pseudo hypertension, as well as improper recording can also end up with a resistant hypertension. Another very common group we call is OSA, obstructive sleep apnea, panic disorders, hyperaldosteronism, anxiety. All this can add up into resistant hypertension. So try to rule out this and then only add the additional drug. So whenever you come across a person in whom you have given 3 drugs, one of them is diuretic and still blood pressure is not under control, you try to rule out all these conditions and then only add a 4th drug. And keep that thing in mind. Proper blood pressure measurement, sodium, diuretic, steroid, oral contraceptive pills, sympathomimetic drugs, OTC products, which is herbal preparation, Ayurvedic preparation containing good quantity of steroids, alcohol intake, secondary hypertension, non-adherence to treatment, as well as white coat hypertension, mask hypertension, etc. can be hyperaldosteronism, pseudo hypertension, OSA, anxiety, panic disorder can be a cause of resistant hypertension. Keep that thing in mind. What is pseudo-resistant? Pseudo-resistance means poorly controlled hypertension that appears to be resistant to the treatment, but actually it is attributed to these factors, and there are very common factors. These are some of the common factors: white coat hypertension, poor adherence, suboptimal antihypertensive treatment, poor adherence to antihypertensive treatment, dietary lifestyles, etc. That is sodium intake, oral contraceptive pills, all those medicines they are taking, and inaccurate measurements. So these are the causes for pseudo resistance, or we call pseudo hypertension. The commonest etiology as far as primary, or we call essential, or we call idiopathic, that accounts for 94 to 95% of the cases of hypertension. So remaining 5% are secondary. Of that 5%, 90% of this 5%, 90% is renal, in which major causes are renal parenchymal and renovascular. Renovascular, renal artery stenosis may be congenital, fibrodysplasia, or maybe atherosclerosis. While renal parenchymal, most common acute glomerulonephritis, chronic glomerulonephritis, chronic pyelonephritis, and chronic disorders of kidney like CKD due to diabetes and other causes, polycystic kidney, etc. Those will be in a renal parenchymal disease. Among endocrinal, the most common is primary hyperaldosteronism, pheochromocytoma, and Cushing's. Very rarely acromegaly. In vascular, coarctation of aorta, aorta arteritis, etc. Among drugs, NSAID, steroids, oral contraceptive pills, and once in a while cyclosporine. In miscellaneous, this is now coming up. This is a very common cause. That is we call as obstructive sleep apnea. So these are the common conditions which can produce secondary hypertension group. But they are accounting for only 5%. And out of that 5%, 90% of that 5% is renal. And another big group is endocrine. So renal and endocrine accounts for almost 95% of, or we can call 99% of that secondary groups. Rest is vascular, drugs, miscellaneous group. Among those idiopathic group, the risk factors are modifiable risk factor or we call controllable risk factor. This is a big list. You should try to go through all this list. Non-modifiable like age, sex, family history, race, hereditary, etc. I'm not going into detail regarding this. At your leisure time, you can go through that. We call as a risk factor for atherosclerosis. So you can go through at leisure time. Modifiable, non-modifiable. Most common, obesity, anxiety, anger, your food habits. So sedentary lifestyle, diet, anxiety, stress, anger, smoking, diabetes, hypertension, obesity. All these are risk factors, and these are all the causes of secondary. This is little bit in more detail. You can go through at leisure time what we have not mentioned before. Some of those cases are responsible, say like cocaine, etc. In metabolic, diabetes, toxemia of pregnancy, and in pregnancy there are also other causes. In neurogenic, raised intracranial pressure. So go through at your leisure time. This is renal parenchymal. This is renal artery stenosis. Renal artery stenosis. These are renal parenchymal. This is polycystic disease. And most common cause is acute glomerulonephritis. This is Cushing. This is obesity and obstructive sleep apnea. This is hyperaldosteronism. Cushing, hyperaldosteronism, cardiometabolic syndrome, and obstructive sleep apnea group. In pregnancy, you can come across what we call as a HELP syndrome, hemolysis, elevated liver enzymes, low platelet, and also you can come across preeclampsia, eclampsia. Preeclampsia is proteinuria with edema, hypertension after 20 weeks of pregnancy, and eclampsia is preeclampsia with seizures. When you come across this particular group, the most important part is a blood pressure recording. Have a proper blood pressure recording, fundus examination, urine analysis, CBC, risk factors, and target organs examinations, investigation for target organ damage, investigation for risk factors. For risk factor, fasting lipid profile, uric acid, and you go for a fasting glucose and GTT, or we call prospandium. Blood chemistry, you can go for sodium, potassium, and creatinine to find out kidneys affected or not in target organs, as well as it will help you to identify whether the person has got previous kidney damage. Potassium will help to identify hyperaldosteronism and other disorders like Cushing, etc., endocrine disorders. Even it will be abnormal in a case of a CKD. So try to identify all those and have a 12-lead ECG to find out effect of hypertension on cardiovascular system. These are the investigations which are done for identifying asymptomatic organ damage, which is good number of time even present in a person with a pre-hypertensive. So pulse pressure measurements, ECG, if ECG is showing LVH, echocardiography is showing you LVH. carotid wall thickness we call as a carotid intima thickness, CIMT, carotid intima media thickness. You try to identify by intravascular ultrasound. Carotid femoral pulse wave velocity, ankle brachial index. These are some of the conditions which you will be able to pick up a person with a early atherosclerosis. In a CKD, eGFR calculation will help you a lot, and microalbuminuria. Try to calculate all this. It will help you to give you a early indication that person is getting a damage because of hypertension, and you will be able to pick up pre-hypertensive groups. Whenever you measure a blood pressure, there are non-invasive measure and invasive. Invasive are usually not utilized. They are mainly done in a ICU or in a critical care unit. You have to put a probe or you have to put a catheter into aorta and measure the mean aortic pressure, or you put a probe into pulmonary artery and measure the mean pulmonary arterial pressure. A non-invasive technique is we call as a sphygmomanometer. By a sphygmomanometer, you measure what we call as a home blood pressure monitoring, office blood pressure monitoring, and ambulatory blood pressure monitoring. Usually, what we use is auscultatory method, and the commonest instrument which is utilized is a mercury instrument, and another common instrument which is utilized is aneroid. Yes, you can also utilize a digital instrument. You can measure a blood pressure by palpatory method or oscillatory method. These are not proper, but before doing a auscultatory method, always do a palpatory method. That will help you to identify auscultatory gap. So try to identify that. Whenever you measure the blood pressure, best instrument is a mercury blood pressure instrument. Measure in an office, measure at home, measure at ambulatory. By and large in an office, we commonly utilize mercury instrument, aneroid, or we call it a digital. Office blood pressure monitoring, or we call clinical blood pressure monitoring. Home blood pressure monitoring instruments are usually digital. They are rarely what we call as a mercury or aneroid. By and large, they use digital. In ambulatory also, they are digital. And in an ambulatory oscillatory blood pressure monitoring, there is a special instrument which measures by means of oscillations, and that is a best instrument available. It is a costly instrument, but it is the best method of measuring a blood pressure. This blood pressure you can measure in supine posture, that is the best, while ambulatory blood pressure monitoring is usually measured in a sitting posture. Home blood pressure monitoring will be also done by and large in a sitting posture. By and large in a office also, majority of people, they do a blood pressure monitoring in a sitting posture, but ideal is supine posture. Whenever you want to identify, differentiate a postural hypertension, you measure the difference between supine and sitting. In supine, it will be high. When a person stands up, and if there is a fall of blood pressure, more than 20 millimeter of systolic blood pressure, you will label that as a postural hypertension, and that is the mode in which you can diagnose the person of orthostatic hypertension, or we call postural hypertension. Measure that way. First time when the person comes to you, measure the blood pressure in both upper arm. It will help you to rule out atherosclerosis, coarctation of aorta, arch of aorta aneurysm, atherosclerosis in the subclavian arteries, etc. It will help you to differentiate that, and once in a while you will also be able to pick up a condition in a thoracic aorta if you measure the blood pressure in upper arm and lower limb. So when you measure the blood pressure in upper arm and lower limb and compare the two, you will be able to differentiate arch of aorta and thoracic aorta disorders like aneurysm, coarctation, atherosclerosis, occlusions, etc. and even in a case of a Takayasu disease. Another mode of taking a blood pressure is at a wrist, and that is by a digital instrument which is like a wristwatch. You can take a blood pressure at ankle and wrist and identify what we call as an ankle brachial index. And that may be one of the way in which you can identify an early atherosclerosis. There are some instrument which you put a finger in that particular and that will give you a blood pressure recording. It is not an accurate but can be a rough estimation. Lower limb blood pressure monitoring is good number of time helpful to differentiate some of the condition which are there in a thoracic aorta. If you come across a lower limb blood pressure which is very high and there is a very wide pulse pressure, it is called as a Hill's sign. And there is another sign we call as a Menes sign. So this is positive in case of what we call as a aortic regurgitation. So blood pressure monitoring in different situations, that is position, office, home, ambulatory, will help you to differentiate mask hypertension, white coat hypertension, stable, unstable, labile, accelerated, etc. So all those can be identified if you use ambulatory or home blood pressure monitoring based by ambulatory blood pressure monitoring, because this will give you a multiple readings. So these are all the different methods by which you try to identify. And whenever you are measuring, always try to measure a blood pressure in a right upper extremity. First time in both extremities. Ambulatory ankle brachial index should be measured in a person in whom you are suspecting atherosclerosis. Lower limb, I have already told you in which condition you try to measure. Supine, sitting, why you measure in supine sitting, all those, and in an erect posture. Whenever you measure a blood pressure, you must take a precaution. Instrument should be properly calibrated. That should be of a best quality, and as far as possible, mercury is the best. If not available, you can use digital, but that should be a best and calibrated instrument. Avoid smoking, caffeine, like tea, coffee, exercise, minimum 30 minutes before measuring a blood pressure. Person should empty out his bladder. Sit quietly for at least minimum 5 minutes before measurements. And during that particular time, should remain still during the measurements. That should be a good support to the limb while you are measuring a blood pressure. BP cuff should be at the level of the heart level. And the base of the mercury instrument should be at the level of the heart. The cuff size should be according to the size of the arm. It should cover up 80% of the arm circumference, and it should be adequate enough to cover up the major part of the upper arm. The lower border of the BP cuff should be at least minimum 2 fingers above the cubital fossa. Don't take the measurements with the clothes on. This is the major drawback which is being done. Measure the blood pressure in both arms and use the higher readings. Take 2 or 3 measurements at 2 or 3 separate occasions and then only label the person as hypertensive. Same thing is mentioned. What are the precautions you take? And when you lower the pressure in the cuff, lower it very gradually, 2 millimeter per second. Don't lower it very fast. It will give you a false interpretation. And whenever you elevate the blood pressure in a BP cuff, it should be above the palpatory systolic blood pressure, or at least above 200 or more than even 210. So try to do that. Always use a office blood pressure monitoring, and in case of a doubt, have a ambulatory or a home blood pressure monitoring. It will help you to rule out mask hypertension, white coat hypertension, and labile, stable, unstable, accelerated, etc. It will help you to differentiate those. This is all the indications of home blood pressure monitoring and ambulatory blood pressure monitoring. You can go through at your leisure time. Suspicion of white coat, suspicion of a mask hypertension, white coat hypertension effects, then you can identify some of the condition, discordance, then resistant hypertension, etc. You try to go through all this list. This is the difference between ambulatory, home blood pressure, clinical. What is the best? Best is ambulatory blood pressure monitoring, but go through at your leisure time. I am skipping over that. And this is how you identify. I've already mentioned how you identify the mask hypertension, how you identify the white coat hypertension. So office, isolated clinic, blood pressure monitoring, and white coat hypertension. So try to, office is also called as a white coat hypertension or isolated clinic hypertension also. This is ankle brachial index. You measure the blood pressure at radial and you measure the blood pressure at ankle. So by measuring that, you try to identify ABI index. And if ABI index is becoming less than 0.9, it is in favor of atherosclerosis, early atherosclerosis. This I already discussed before. What is the importance of blood pressure monitoring in lower limb, and what is the difference between upper limb, lower limb, what is the difference between the two sides, right upper limb and left upper limb. So all those conditions. Now step 1, confirm that person is hypertensive. So confirmation is only by blood pressure recording. We have already mentioned how accurately you measure the blood pressure. History and symptoms will help you to suspect primary and secondary. And do physical examination, cardiovascular system examination, etc. Depending upon what is your suspicion, you should do ambulatory, home, office, or clinical blood pressure monitoring. Best is ambulatory blood pressure monitoring. Try to measure by that. It will help you to identify many conditions. After measuring that, depending upon the figure, we put them into different stages. Pre-hypertensive, stage 1, stage 2. Depending upon the ambulatory blood pressure monitoring, labile, stable, unstable, accelerated, mask hypertension, white coat hypertension, etc. And depending upon the figure, isolated systolic, diastolic, and then with the history and other investigation, we call compelling indications like diabetes, CKD, pregnancy, complicated conditions, endocrine disorders, all those conditions. Ischemic heart disease, congestive heart failure. So to find out the compelling indication and primary or secondary, you will have to undergo investigation. We have already mentioned before what investigation you do. Also do the investigation to find out the risk factors. Do the investigation to find out the target organ damage like cardiovascular system, renal, eye, peripheral arterial disease, brain, etc. Also, in case of a clinical symptoms, presence of symptoms, and if you are suspicion of a hypertensive crisis, try to identify whether it is urgency or emergency. Because in emergency and urgency, you need a treatment immediately. You have to start the treatment immediately. And in case of emergency, you require a IV therapy. And sometime also in a case of urgency also, you might need a injectable. And if a person does not have a hypertensive emergency, maybe stage wise anything, maybe stage 1, stage 2, maybe in any one of this group, or compelling indications, or maybe primary or secondary, you start a treatment, that is total lifestyle changes, or a drug we call as a ABCD. Depending upon the compelling indications, etc., you decide which drug will be better. We'll be going through all those now, one by one. So also identify primary or secondary and then decide what drugs you want to. This is what we have given in a previous slide. Same thing is mentioned. Use this figure for putting them into a group. Diagnostic workup, cardiovascular system risk factor workup, and assess the identification of the cause, primary or secondary, and in secondary what are the etiology. Try to work up that, and entire thing is mentioned here. What we have mentioned before, what we have discussed before is mentioned here. So try to identify that and then only decide regarding a treatment. You know very well that hypertensive treatment has been necessary, or it is absolutely necessary in primary or secondary. It is whether it is primary or secondary, and it is always a lifelong disease. So it has to be for lifelong. Yes, in case of secondary, there are some treatable cause. You treat those cause, it is reversible. and person may not require a further treatment. You know, blood pressure can be controlled but cannot be cured. This should be the thing which should be explained to the person. And we do have a blood pressure control to reduce the risk factor for stroke, MI, congestive heart failure, CKD, etc. Contraindication is only one. That is, if a person is hypotensive or in a shock stage, maybe normovolemic, maybe hypovolemic, it is contraindication. And if any person who is sensitive or he has developed a complications secondary to a drugs, that drug should not be used. You can use the another drug. So there is no specific contraindication, but contraindication for a specific drug if a person is sensitive or he gets a side effects or toxicity. So again, we call non-pharmacological is a lifestyle modification, and pharmacological is ABCD and other drugs, which is for risk factors like statin, aspirin, clopidogrel, etc. And surgical treatment is mainly required in a secondary groups, say for renal artery stenosis, pheochromocytoma, coarctation of aorta, eclampsia, etc. In eclampsia, say termination of pregnancy. In coarctation, dilatation with stenting. Pheochromocytoma, surgical removal. Renal artery stenosis, stenting or surgical repair of a renal artery. So these are those particular. And in case of a resistant hypertension, renal denervation, which can be open or by means of a catheter. So these are some of the procedure. And in this condition, it is reversible. Or we can call, you can have a cure sometimes in this condition. Otherwise, basic is non-pharmacological lifestyle modification, and pharmacological is a drugs. So non-pharmacological, pharmacological, surgical treatment, and treatment for resistant hypertension. So lifestyle modification, antihypertensive treatment supported by lipid lowering, diabetes control, etc. and antiplatelets becomes the supportive line of treatment. A healthy meal is the first thing in a total lifestyle modification. This is an unhealthy meal. You should not have this unhealthy meal. Whenever you do a very nice lifestyle modification like weight reduction, if you reduce more than 10 kg, you can reduce your blood pressure from 5 to 20 millimeter. If you do a DASH dietary course, we call as a dietary approach to stop hypertension, it is called DASH. It can reduce your blood pressure from 8 to 14 millimeter. Sodium restriction can reduce from 2 to 8. Physical activity and mental stress reduction can reduce from 4 to 9. Alcohol restriction 2 to 4. When you put all this together, it can reduce from 20 to 55 millimeter of mercury, and this is a very, very good without any drugs, without any side effects. So if any person who does a rigid lifestyle modification can reduce up to 20 to 55 millimeter of mercury in systolic blood pressure. So you can see a very good effect of all these things. But this person is doing a treadmill, but treadmill is done by a dog, is not doing an exercise, is having food packets which is from McDonald's, is having a Coke. All these are worst for hypertension. So try to avoid all those things. When you go to the market and you go for purchasing one item but you see lot of items, you get confused. So we also get confused whenever there are more than 200 to 300 different types of antihypertensive drugs, but we have to select only one. So while selecting one from 200 to 300 items, it becomes very difficult. So selecting an ideal antihypertensive becomes very, very difficult. So it is very difficult what to select. So it is same like this person when he is having lot of ladders and he wants to see on that side, he doesn't utilize any one of this. He is confused. So it happens, you have got many resources. So during many resources, it becomes a difficult matter to selection. So always use the best, but select properly. And while selection, it is like selecting a life partner. You want a life partner which should be long acting for 24 hours. That is, you select a drug which is having a 24 hours action. which improves quality of life. It should be from a very good quality, means from a standard pharmaceutical company, relatively cheap. This is very difficult. If you want a good quality, they are usually expensive. But good quality with a low price are the best drugs, because it can be available for any person. It should be easily available in any corner of the country. It should be powerful and effective, and as effective for 24 hours. At the same time, we know that no one is Sarvagun Sampan. We want 36 gun in one person. Same way, we want all these things in one drug, which is not possible. Simultaneously, drug should be, because we have got only one choice. Drug should have no side effects, no toxicity, no interaction. Not possible. Hence, we are having 200 to 300 different types of drugs. But if any drug which is having a good blood pressure control, having a little improvement in quality of life, it is relatively cheap, easily available, powerful and effective, and also having a pleiotropic effect on cardiovascular system, on lipids, on kidney, we call nephroprotective. It is a base drug. Try to select that. And drug should block RAS system, or we call it should protect your target organs. If that drug is available, that is the wonderful drug. We know that we divide into 4 groups, A, B, C, D. It is not that anybody can dance. We will have a part 1, part 2. Later on some year you will come across part 3, part 4, part 5, etc. But we use this word A for ARB, ACE inhibitor, B for beta blocker, C for calcium channel blocker, D for diuretics, and first we have got another group we call as a centrally acting or vasodilator group, and miscellaneous. So first choice is always ARB, ACE inhibitor, but C comes before B, so we call second choice is CCB. D is before B, that is diuretic is the third choice, and fourth choice is beta blocker, and fifth choice is centrally acting or vasodilators. So vasodilators and centrally acting drugs comes in a fifth drugs, and this is the mechanism of action. I don't go into detail. A drug which is acting at this level is called centrally acting drugs. The drug which is acting here is vasodilators, and one of the very good vasodilator is CCB, and there are also what does not belong to CCB. They are also vasodilators. There are drugs which is acting on a heart. We call as a cardioselective, and most common is beta blocker, and there are CCB which is acting on the heart level and which acts at the RAS level. We call as a ACE inhibitor, ARB. And diuretics which is acting at the level of the kidney on the loop of Inles and distal convoluted tubule. All these are where they are acting. So if you select a drug which is acting at the different areas, say centrally acting drugs with beta blocker, centrally acting drugs with ACE inhibitor, ARB, ACE inhibitor with diuretics, they are acting at a different level, you get an additive effects. But if you use a drug which is acting at the same level, it does not improve the effects. So try to identify. So you've got another group we call as a renin inhibitor, which will be acting at this level. It will inhibit the renin and does not allow the angiotensin to be converted into angiotensin 1. And this is ACE inhibitor will be acting, not allowing the angiotensin 1 to be converted into angiotensin 2. Aldosterone antagonist is acting at the level of aldosterone, and ARB is acting at the level of AT1 receptors. So this is the site where it is acting, and you know what will be the benefit, what will be the advantage, what will be the disadvantage. We are going through the common groups now. ACE inhibitor or ARB. I am talking about ACE inhibitor. All these other things remains common for ARB also. In ACE inhibitor there are drugs name. I am giving the basic compound: captopril, enalapril, lisinopril, ramipril, benapril, fosinopril, and plus there are many others. Indication: hypertension with congestive heart failure, ischemic heart disease, cerebrovascular disease, coronary artery disease, post-MI, diabetes mellitus, it is a first drug of choice. In a CKD, it can be used if GFR is up to 50. Now, some people say that you can use up to even 30, but less than 30, don't use ARB or ACE inhibitor. First line of drug of choice in case of hypertension with these groups, or it can be utilized with CCB, beta blocker or diuretic. You can combine with any. Yes. Also in case of a person with hyperlipidemia, you can use some benefits, particularly with telmisartan. It is having a pleiotropic effect. In a diabetic nephropathy or a person with diabetes, it prevents proteinuria or it reduces proteinuria. That is again a pleiotropic effect. In a scleroderma crisis also, it can be a drug of choice. But main cause, main indication is congestive heart failure, ischemic heart disease, cerebrovascular disease, post-MI, diabetes mellitus, and even in a case of a CKD. In all these conditions, it is a drug of choice. Contraindication. It produces the major side effects like postural hypertension, absolute contraindication in pregnancy, absolute contraindication in CKD if it is less than, GFR is less than 30, and also in a case of AKI, 100% contraindication. Relative contraindication, if a person is getting a chronic cough, which is because of ACE inhibitor, you will have to stop and switch over to ARB or another drug. Don't combine ACE inhibitor with potassium sparing diuretic like triamterene or what we call as potassium sparing diuretics, amiloride. In those particular compound, you don't try to combine. Also, as far as possible, don't combine ACE inhibitor with aldactone or we call spironolactone. By and large, don't use in a peripheral vascular disease or peripheral arterial disease. In this also, you should not use. There is one major drawback because a person who is having an ACE inhibitor can develop angioedema and sometimes this can be life-threatening. Enalapril you can go from 5 mg to 40 mg. Being a short acting, you will have to give BID. Lisinopril is a long acting. Again, dose can be from 2.5 mg to 40 mg. The dose is usually OD. Ramipril is again long acting. You can give 1.25 mg to 20 mg OD. Good number of time it is given at the bedtime. All these are not potent antihypertensive. So, depending upon the requirement, you can go to those particular doses. These are all marked out. You can go through at leisure time. ARB, same thing. Only I am talking regarding a drug. There are losartan, telmisartan, olmesartan, and azilsartan. Losartan 25 to 100 mg short acting, so you have to give BID doses. Telmisartan is 20 to 80 mg OD dose. Olmesartan 10 to 40 mg because this is 2 times more powerful than telmisartan. Also, azilsartan is also 2 times more powerful than telmisartan. So, they are also OD doses, but they are half the dose of telmisartan. So, try to remember all this. There are other compounds like valsartan, candesartan, etc. These are lot of trials are being done and they are found to be very effective. But because of the cost factor, the use is relatively little bit less. And they are utilized in a post-MI and ischemic heart disease group. So, these are the advantage of ARB, etc. And this is the advantage of a telmisartan. It has got a pleiotropic effect on what we call as a heart. It reduces the enlargement of the heart, means it helps in remodeling, and also beneficial effect in a congestive heart failure. It has got a beneficial effect on the lipids. So, if a person is hyperlipidemic, it has got a pleiotropic effect. It has also got a pleiotropic effect on a visceral fat. On a proteinuria is reduced. So, it helps in progression of a CKD and partial reversal of CKD. It also helps in reducing insulin resistance, reduction in a HOMA index, and reduction in a HbA1c. So, It is also helpful in diabetic mellitus. It has got an effect on decreasing arterial stiffness. So it reduces the peripheral vascular resistance also. So this is also one additional pleiotropic effect. And also it has got the effect on Papa A receptors. It is a partial activation. And it reduces blood pressure for 24 hours. So these are all the pleiotropic effects. So these are the benefits of ACE inhibitor, antiproteinuric. So protection in a kidney for reduction in a proteinuria. So it reduces the CKD possibility. Regression of LVH, so we call remodeling. So it improves the survival of in a person with a heart failure. So again it helps in remodeling, reduces the mortality. It is also useful in a graft survival. It reduces the complications which is induced by fibrosis. It also reduces the production of angiotensin 1 and also has got a benefit effect of angiotensin concentration which increases by angiotensin blockade. So these are all the beneficial effects. Now we come to the beta blocker. Beta blocker is a fourth drug of choice, but it is very beneficial in young individuals, in adults, young adults, mitral valve prolapse, we call HOCM, hypertrophic obstructive cardiomyopathy, in angina, or we call as a stable angina, it is a drug of choice. Also, if the person is hypertensive with ischemic heart disease, post-MI, unstable angina, it is a drug of choice. In congestive heart failure, dissecting aorta or dissecting aortic aneurysm, in that also it is a drug of choice. In a person with anxiety also it is a drug of choice. They say that a person who is having malaria, beta blocker can be helpful. In hyperthyroidism, because the person is having hyper secretion during stress, that is blocked by beta blocker. So if a person is hypertensive with thyrotoxicosis, it is beneficial. With tachyarrhythmia, it is beneficial. In a pheochromocytoma, it can be given along with pentalamoine, etc., or phenoxybenzamine. So it is a second drug of choice in pheochromocytoma. In eclampsia, labetalol, which is a alpha beta blocker, can be of a drug of choice in case of an eclampsia or hypertension during pregnancy. So these are all the indication where it becomes, instead of 4, it can become first drug of choice. So use that. What is a contraindication? Severe bradycardia, complete heart block, sick sinus syndrome, first degree AV block, second degree AV block. It should not be combined with diltiazem and verapamil. These are the major contraindication. Relative contraindication in old age person, type 2 diabetes, where it can block the effect of hypoglycemia in a person. In a person with peripheral vascular disease, peripheral arterial disease, Raynaud's phenomena, relative contraindication. So these are the relative contraindication, these two. These are absolute contraindication. By and large, don't use if a person is having libido or if a person is having COPD or asthma. But even in these cases also, nowadays they are being used because we have got a selective beta blockers. It can increase lethargy. It can worsen left ventricular failure or cardiogenic shock. So in this group also, sometimes it is not utilized. So these are there. Atenolol is very powerful. You will have to give 25 milligram to maximum 100 milligram. It is a long acting, so you can give OD or BID doses. Metoprolol is available in a sustained release preparation or extended release preparation. So you can utilize from 12.5 milligram to 100 milligram depending upon the indications. Now this is the drug which is most commonly utilized, being a beta selective blocker. Bisoprolol is very powerful. It is 2.5 milligram to maximum 10 milligram and it is a long acting drug, so it is a OD dose. So these are the common drugs which are these are the 3 common drugs. There are other drugs like carvedilol, nevedilol, which are utilized mainly in case of ischemic heart disease, post-MI, etc., and for remodeling purposes. So in those conditions, You can use carvedilol, nevedilol. And labetalol is utilized in a person we call during pregnancy and in case of emergency in an injectable form. So these are all the conditions where you utilize. And I'll show you in the next slide, combined together, how this beta blocker is effective, and it is a first drug of choice. It is a first drug of choice if a person has got ischemic heart disease with hypertension, congestive heart failure with hypertension, stable angina, unstable angina with hypertension, acute MI with hypertension, tachyarrhythmias for remodeling purposes, and if a person is hypertensive, it is the first drug of choice. So remember all this. These are all cardiovascular conditions. So if you get cardiovascular condition, say in an unstable angina, for plaque stabilization also, beta blocker becomes a drug of choice. Now we go to another compound we call as a calcium channel blocker. They are divided into different generation. First generation, second generation, third generation, fourth generation. First generation is nifedipine, second generation is nicardipine and felodipine, third generation is amlodipine, and fourth generation is cilnidipine. This cilnidipine is effective on L receptor and T receptors, which are present in glomerulus, and that helps in reducing intraglomerular pressure. But these are not powerful blood pressure drugs. They reduces blood pressure mildly. There are some drugs which we call as this group, diltiazem and verapamil. These particular drugs are mainly utilized for tachyarrhythmias. So we divide into two big groups, vasodilators and cardiospecific. These are more cardiospecific, means they are utilized for what we call as cardiac arrhythmias, tachyarrhythmias. While these are what we call as the vasodilators. They are more vasodilator than cardiospecific. But all these conditions, they produces vasodilatation, and because of vasodilatation, fall of blood pressure, and they produce reflex tachycardia. So in a person with tachycardia, avoid using these drugs. We call second generation, first generation, third generation, and fourth generation. These are CCB, which are not put into dihydropyridine groups. So dihydropyridine groups is first, second, and third generation and fourth generation, and non-dihydropyridine groups is utilized mainly for cardiac arrhythmias. This particular may have a pleiotropic effects, what we call as a fourth generations. And these are the drugs which are mainly utilized for supraventricular tachyarrhythmias, not for ventricular arrhythmias, and for ischemic heart disease group. Well, these are mainly utilized in a person with CKD, peripheral arterial disease, and isolated systolic hypertension. Again, I am repeating, this group, nifedipine, nicardipine, amlodipine, cilnidipine, for isolated systolic hypertension, or we call old individual, peripheral arterial disease, and CKD. This is a drug of choice in this group. So first generation, second generation, first generation nifedipine, second generation nicardipine, third generation amlodipine and azaldipine, and fourth generation is cilnidipine. Now these are acting on L receptors. These are acting on L and N receptor also. So depending upon that, it reduces the heart rate. These are all those which reduces the heart rate. Well, this will decrease the elevated heart rate also. This will produce tachyarrhythmias, tachycardias. So they should be avoided in a person who are having tachycardia. So benedipine and cilnidipine will be usually a drug of choice in case of a CCB. Nowadays, azalnidipine is in a market which is having an effect on L as well as a T receptor, which is also reducing the heart rate. And there is another compound called efanodipine, azalnidipine, and manidipine. So combining together, I have already told you that it is a drug of choice in an old individual, CKD, AKI, pregnancy. During pregnancy also, it is a second drug of choice after labetalol. In case of atrial flutter fibrillation, diltiazem and verapamil is a drug of choice because these are supraventricular tachyarrhythmias. Nifedipine can be utilized in a hypertensive crisis, but this is outdated now. In a person with a bradycardia, you can use amlodipine and nifedipine. In hypertensive crisis, particularly with pheochromocytoma, dicardipine is a drug of choice. In case of eclampsia and preeclampsia after labetalol, amlodipine and nifedipine is a drug of choice. Don't use CCB in a person with tachyarrhythmias, particularly amlodipine and nifedipine. They are usually not utilized in a congestive heart failure and ischemic heart disease. Diltiazem and verapamil is not utilized in bradycardia, and they are not combined with beta blockers. A person, if he develops an ankle edema because of amlodipine, change it over to the S-amlodipine, or we call chirally formed amlodipine, or you can change over to other compounds like we call as cilnidipine, third generation and fourth generation groups. Some person also develops another complication we call as a gum hypertrophy, which is a complication which usually is detected very frequently by a dentist, and by stopping calcium channel blocker, gum hypertrophy will reverse back. So that is one of the another contraindication for CCB. Amlodipine is a long acting drugs, so usually OD right from 2.5 milligram maximum 20. Higher the dose, the chances of ankle edema, gum hypertrophy, tachycardias, etc. are more common. So take care of that. Nifedipine is a short acting drugs. Sustained release preparation can be utilized as a OD or BID doses, and dose maximum is 60 milligram. Nicardipine maximum dose is 120 milligram from 10 to 120 milligram. Usually OD dose, or sometime it is given in a split up dose like BID. Felodipine is a more vasodilator, 2.5 to 20 milligram. So it is a drug of choice in a case of where you want a peripheral vasodilatation. Diltiazem is mainly diltiazem and verapamil. Diltiazem from 90 milligram to 240, they go even up to 480 milligrams in a selective cases and where the facilities are available for what we call as an ICU. Verapamil you can go up to 360 milligram, and this can be utilized also in an injectable form in a case of a supraventricular tachycardia with unstable hypotension. So in that particular group, now azelnadipine dose is 8 milligram to maximum 16 milligram OD dose, and cilnidipine is from 10 milligram to 20 milligram. Even sometime we go up to 40 milligram. So these are all the conditions where CCB is utilized, indication and contraindications. Now we come to diuretics. In diuretic, we have got a thiazide diuretic, we have got a loop diuretic, and we have got potassium sparing diuretic. By and large, the maximum diuretic which are being utilized is a loop diuretics, which can be furosemide, which can be torsemide, which can be chlorthalidone. So commonest diuretic which is utilized is chlorthalidone, which has got an advantage above hydrochlorothiazide. Hydrochlorothiazide can be utilized from 6.525 to maximum 50 milligram. Higher the dose, the chances of hyperuricemia, hypertriglyceridemia and hyperglycemia is more. Hence, hydrochlorothiazide should be utilized in a lower doses. So, to want a therapeutic effect, you will have to go up to 50 milligram. So, because of this reason, slowly hydrochlorothiazide is almost out of market. Furosemide and torsemide is mainly utilized in a person in a hypertension with congestive heart failure rather than pure hypertension. Hence, in a pure hypertension, chlorthalidone is a drug of choice. Usually it is combined with ACE inhibitor, or it is combined with beta blocker, or it is combined with CCB, depending upon what is the requirement. And maximum dose is 12.5 milligram. And again repeating, furosemide and torsemide is a drug of choice in a person with congestive heart failure. So, potassium sparing diuretics are not commonly utilized for hypertension. They are mainly utilized along with other drugs. So there are three drugs: spironolactone, amiloride and triamterene. Spironolactone is very frequently combined with furosemide or with torsemide, and that is utilized in a person who is having hyperaldosteronism, particularly in a congestive heart failure, ascites, etc. Very commonly in a person with ascites. So in this particular group, it is most commonly utilized in combination with torsemide or in combination with furosemide. So in that particular condition, it is a drug of choice. So it is combined with torsemide or it is combined with furosemide. But whenever you are using this, always keep in mind, whenever the potassium sparing diuretics are utilized, and if they are utilized along with ACE inhibitor, so if ACE inhibitor is given and diuretics are given, keep a watch for potassium. So that should be there. In any person who has got a volume overload, diuretic is a drug of choice. Hyperaldosteronism, spironolactone is a drug of choice. Hydrochlorothiazide dose usually is 6.25 to 50. Furosemide is 20 to 80 milligram. Sometime in a person with a congestive heart failure, we go up to even double the dose, and even sometime we give 80 milligram IV. Aldactone maximum dose is 200 milligram, but keep a watch on potassium. Contraindication of diuretic, absolute contraindication, AKI, CKD, end stage renal disease, and in an old age person more than 65. Try to avoid, because excessive use of diuretic will produce postural hypertension, and it is absolutely contraindicated in AKI, CKD, and end stage renal failure. As some of the diuretics like hydrochlorothiazide increases uric acid, increases lipids, and increases sugar, it is contraindicated in diabetes, gout, and also in a hyperlipidemia. And this diuretic, potassium sparing diuretic, should not be combined with ACE inhibitor or ARB, and they are contraindicated in a person with hyperkalemia. Because of furosemide and torsemide, it can produce hypokalemia, hyponatremia, while potassium sparing will produce hyperkalemia. And this use of larger dose can produce orthostatic hypotension. There are additional advantage of diuretic in this condition. I am keeping this slide for a second. Have a pause, go through that. It is helpful in heart failure, hypertension, severe edema, pulmonary edema, acute renal failure. We give a booster dose, or we call therapeutic dose, hypercalcemia, hyponatremia, calcium nephrolithiasis, nephrogenic diabetes insipidus, Liddle syndromes, lithium-induced diabetes insipidus, primary hyperaldosteronism, edema of pulmonary hypertension or portal hypertension, liver cirrhosis, also in case of epilepsy, acute mountain sickness, raised intracranial pressure, glaucoma, metabolic alkalosis, nephrotic syndrome, AKI, CKD, cystinuria, ascites, portal hypertension, hyperkalemia, hypokalemia, poisoning, etc. These are a big list. Some other time we'll go through the chapter on diuretics. So in that particular, I'm giving a little advantage of a chlorthalidone. It is having an advantage of diuretic plus we call pleiotropic effect. So it is helpful in hypertension, congestive heart failure, diabetes with hypertension, in a metabolic syndrome, isolated systolic hypertension, and it can be utilized safely in a person, elderly person. It has got a cardioprotection by reducing the congestive heart failure. It reduces LVH, also helpful in ischemic heart disease, cerebrovascular disease. It is also having a pleiotropic effect on antiplatelet, angiogenesis, vascular permeability. Hence, it is benefited in a congestive heart failure. Now we are talking about alpha adrenergic blockers. Alpha adrenergic blockers, they are very helpful in certain conditions, but they are not the first drug of choice. They should be utilized in a person in a secondary line of treatment. That is, it is always as an add-on therapy. It is added if a person is having hypertension with BPH, or person is having a resistant hypertension, or person is having hypertension with diabetes mellitus with hyperlipidemia. So minipress is a drug of choice. Minipress is very beneficial in BPH. And if a person is having hypertension, it will be a drug of choice. But major contraindication, BPH is very common in old age. And in old age, it produces postural hypotension or orthostatic hypotension. So whenever you use in a BPH, do take care of postural hypotension. Non-selective adrenergic blocker. Because they are non-selective, they act at a multiple receptors. It is a drug of choice in a pheochromocytoma. In a pheochromocytoma, the first drug, either pentolamine or phenoxybenzamine, is given IV. After the person is stabilized, you add on other drugs like calcium channel blocker or beta blockers. But whenever you use this drug in a pheochromocytoma, keep a watch on postural hypotension. So in a pheochromocytoma, the first drug of choice is pentolamine or phenoxybenzamine. And by and large, the pentolamine is the common drug which is being utilized. And keep a watch whenever you utilize this drug of postural hypotension. We come to another group we call as a centrally acting drugs. That is what we call as drug which is acting at the level of hypothalamus and autonomic nervous system area. And that particular drug is methyldopa, clonidine and moxclonidine. These are the three drugs. Methyldopa is a drug of choice during pregnancy, in eclampsia and preeclampsia. But because of good number of side effects, hepatotoxicity, hypotension, etc., this drug is not commonly utilized. Clonidine is an add-on therapy as a fifth drug, fourth drug, fifth drugs. Maximum dose is 0.6 milligram and it is commonly utilized in the BID doses, TID doses. Moxclonidine will not have a rebound hypertension, but it is not as powerful as clonidine. So clonidine is still a drug of choice. Only drawback is rebound hypertension in clonidine. While both of this, clonidine and methyldopa, will produce postural hypotension, while moxclonidine is having less incidence of orthostatic hypotension and rebound hypertension. So in a person in whom you want to give centrally acting drugs, but you don't want to have these side effects, and if a person is getting rebound hypertension or orthostatic hypotension, give moxclonidine. And maximum dose of moxclonidine is 0.6 milligram OD dose. So that is the dose, and it is mainly utilized as an add-on therapy in a case of preeclampsia, eclampsia, and add-on therapy in a patient with a resistant hypertension. In a pheochromocytoma, clonidine can be utilized as in a clonidine test, but be very careful while you use clonidine in a pheochromocytoma because it can be dangerous sometimes. So it should be tried only in presence of an ICU facilities. There are alpha beta blockers. The most common alpha beta blocker we utilize is labetalol, and it is utilized in a preeclampsia and eclampsia. Maximum dose is 800 milligram, and you can split up that dose into BID dose. While contraindication is only bradycardia and postural hypotension, which are not very common. Carvedilol and nevidilol, they are mainly utilized in a person hypertension with ischemic heart disease and mainly post-MI groups. And carvedilol you can go up to 50 milligram and nevidilol you can go up to 10 milligram. And these are the drugs which are commonly utilized where you do not utilize the other beta blockers, that is metoprolol. In those cases, you can add carvedilol in other antihypertensive drugs or for remodeling, or we call as a post-MI. So these are all the different types of drugs what are available for hypertension. Now this group we call as a vasodilator group, miscellaneous group. Minoxidil, hydralazine and diazoxide and nitroprusside. Nitroprusside and hydralazine are the most common drugs which are utilized for hypertensive crisis, and particularly in a case of a hypertensive emergency. They are available in the form of injectables. But nitroprusside is less commonly utilized. Hydralazine is the most commonly utilized. But now because of the availability of injectable nitroglycerin which is available, so whenever you use IV nitroglycerin, these drugs are almost not commonly utilized. So they are usually most commonly utilized in a hypertensive crisis, particularly hypertensive emergency. In that case, it is given in an injectable form. Very rarely they are utilized for resistant hypertension. The common drawbacks is postural hypertension. Don't use this vasodilator in a person who is having a carotid artery stenosis, renal artery stenosis, and cerebrovascular disorders. In this group, it will produce what we call as a still syndromes, and the organs which is having stenosis will be damaged, like brain and kidney. And these are the doses which are being utilized. Nowadays, the nitroprusside is very rarely utilized. The common utilization is hydrolazine, and much commoner is IV nitroglycerin, NG we call, short form we call as NG. So that is most commonly utilized. Now this is a comparison of all the drugs and the side effects. So what are the side effects and which condition you utilize? So in a ischemic heart disease, the commonest drug which is utilized is beta blockers and ACE inhibitors. In LVH and LVF, diuretic is the first drug of choice. Second drug of choice is the beta blockers. Third drug of choice is the ACE inhibitor, while calcium channel blocker are usually not utilized. In cerebrovascular mortality, ACE inhibitor, beta blocker and diuretics are the drug of choice, while calcium channel blocker usually is contraindicated. In a person with a tachycardia, usually calcium channel blocker will produce tachycardia, while beta blocker will produce bradycardia. So it will be contraindicated in presence of bradycardia. Calcium channel blocker will be contraindicated in tachycardia. In diabetes, the first drug of choice is ACE inhibitor, while you don't utilize diuretic, beta blocker and calcium channel blocker in diabetes. As far as the lipid is concerned, again ARB is having a pleiotropic effect, particularly ARB groups is having a pleiotropic effect. So they are better in that particular, while diuretics, particularly hydrochlorothiazide and beta blocker, that is atenolol, is having hyperlipidemia as a side effects, should not be utilized, while calcium channel blocker is neutral. Fluid and sodium and water retention. Sodium and water retention is more common with what we call as beta blockers and certain calcium channel blockers because of vasodilatory effects. So in those particular conditions, don't use these particular groups. Is that clear? This produces vasoconstriction, while diuretic will have a positive effect. So in a person with a left ventricular failure, congestive heart failure, it is a drug of choice. What we call as a potassium excess, hyperkalemia, certain diuretics, particularly potassium sparing diuretics, should not be utilized, and beta blocker will produce bronchospasm, so it should not be utilized in a person with COPD and bronchial asthma, while calcium channel blocker is a neutral, so you can utilize that. Now ACE inhibitor will produce cough, so it should not be utilized in a person who gets a cough. We call urine analysis, unstable angina and conductive very odd things which is mentioned. So we call conduction. So unstable angina and conduction, particularly beta blocker will reduce the conduction and will produce a bradycardia, so should not be utilized in a first degree AV block, second degree AV block, complete heart block, also in a person with a sick sinus syndrome, etc. should not be utilized. Calcium channel blocker, particularly diltiazem and verapamil, should not be utilized in a person with a beta blocker, person who is already on beta blocker, or person who is having a bradycardia, should not be utilized. And diuretics, particularly hydrochlorothiazide, which increases the uric acid, it should not be used in person who is having a hyperuricemia, while losartan is a drug of choice in a person who is having hyperuricemia. So this is a combined slide. I am having another slide. This is a quiz for you. You can go at your leisure time. Which is a drug of choice in a renal artery stenosis? What is contraindicated? I put all this. So you can go through, but have a genuine quiz for you. So go through. These are all the conditions. These are indications. These are contraindication. Which drugs is contraindicated? Go at your leisure time. I'm skipping over. Yes, this is what we call as a flow charts. Just go through at your leisure time. If the person is having a blood pressure at this level, start one agent. If blood pressure is more than 160/100, start two. Lifestyle modification is common for both. If person is having albuminuria, what drug you will use? If person is having no albuminuria, you can use any one of these drug. You can see this, and then assess the blood pressure control for follow-up. If target is achieved, continue the therapy. If target is not achieved, what you do? Everything is mentioned here. So go through this. We are going to utter all those things. In a simplified manner, we say that younger the individual, first drug of choice is always a ACE inhibitor, ARB. Older the individual, CCB is a drug of choice. As far as possible, don't use diuretic. If it is not controlled by ACE inhibitor and diuretic, or ACE inhibitor, you combine the second drug, and second drug is usually calcium channel blocker or diuretics. In younger individual, ACE inhibitor with diuretic. In older individual, ACE inhibitor with calcium channel blocker. If after that is not controlled, use all the three: ACE inhibitor, calcium channel blocker, diuretic. And even after this, if it is not controlled, in a full therapeutic dose of diuretic, full therapeutic dose of ACE inhibitor, full therapeutic dose of calcium channel blocker. If still not under control, we label that as a resistant hypertension. Now you can add spironolactone, or you can use eplerenone, and that will help you in a resistant hypertension. As a fifth drug, you can use a alpha blocker, beta blocker, or centrally acting drugs, or you can use a vasodilators. The most commonly utilized is alpha blockers, or you can use a beta blocker, or you can use a centrally acting drugs. So any one of these drugs you can utilize. And this is a flow chart, which is the simple most flow chart we can utilize. And this is what we follow in India. Younger individual, that is less than 55 years. Older individual, they say that more than 55. So this is the common we follow in India. So this is the best chart. Again, go have a leisure time, read properly, and you can approach accordingly. Now this is individual. If a person is uncomplicated, whatever we have given here, the same is repeated. Same is repeated. Right? Now, this is follow-up what we have told you in this. This is in follow-up. That is highlighted here. That is highlighted here. You can go at your leisure time. What you do in a follow-up. These are all we call as a compelling indication. Hypertensive crisis, urgency or emergency, coronary artery disease, cerebrovascular stroke, diabetes, CKD, heart failure, plus others. These are all compelling indication, and depending upon the compelling indication, the drug will choose. I have selected this common compelling indication. If the person has got LV dysfunction, or person is having symptom signs of what we call as a failure signs, diuretic is first drug of choice with ACE inhibitor. So this is the most common drug and combination which is prescribed. The second drug which will add, not CCB. CCB is contraindicated. Now beta blocker becomes a drug of choice. So beta blocker, ACE inhibitor and diuretic becomes a drug of choice. Depending upon the indication, you can use the ACE inhibitor, diuretic and beta blocker. And add-on therapy wise, we add on ARB, you can add potassium sparing diuretic like aldosterone antagonist. In post-MI, beta blocker becomes the first drug of choice, ACE inhibitor becomes the second drug of choice, and you can add aldosterone as an add-on therapy. While coronary artery disease, again, beta blocker, ACE inhibitor and diuretic or CCB. While in a diabetes, ACE inhibitor is the first drug of choice or ARB, and diuretic, particularly hydrochlorothiazide, should not be utilized in case of a diabetes mellitus, also in case of what we call as hyperuricemia and hyperlipidemia. And last drug in a case of a diabetes is beta blocker. So beta blocker is contraindicated in diabetes mellitus, while it is a drug of choice in a left ventricular failure, post-AMI and coronary artery disease. So remember this particular thing. In a CKD, ACE inhibitor and ARB can be utilized up to GFR 30, but less than 30, these are contraindicated, and in that case, CCB becomes the first drug of choice. Diuretic is contraindicated, ACE inhibitor is contraindicated, so CCB and beta blocker remains. In a recurrent stroke, ACE inhibitor is a drug of choice, and you may combine with diuretic, but in an old individual with postural hypotension, diuretic should not be utilized. So these are all the common compelling indication which you come across in your everyday practice. I have taken that. And in the next slide, we are just going through what I have mentioned in the diabetes mellitus. This is in a coronary artery disease, drug of choice, first, second, third drug of choice. This is again first, second, third drug of choice. In a person with left ventricular dysfunction, CKD, in atrial fibrillation, what drugs are to be utilized. So all this you can go through your at leisure time. So these are all called compelling indication. Hypertension with something which is present. And this is combination of all those previous slides. LVH, microalbuminuria, cerebrovascular strokes, heart failure, angina, aortic aneurysm, atrial fibrillation, flutter, end-stage renal disease, peripheral arterial disease, isolated systolic hypertension, metabolic syndrome, diabetes, pregnancy, blocks, etc. So these are all those conditions. You can undergo all these are the drug of choice. At your leisure time you can undergo. Now this is one simple thing. Start with mono. If not control, go to poly. Means add on one. So always use a small dose. Don't use a toxic dose. Larger the dose, the toxicity is more. You combine more and more toxic material, you get more and more chance of toxicity. Poly, you can use small dose of multiple different agents which are acting at different levels, so you get the best effect. And this is the way they say. Sorry. So choose one agent from each group. So small doses, chances of side effects are minimum and chances of toxicity are minimum. This is the best way of combining. So polytherapy is always better than monotherapy, but initially in a grade 1 and early stage, monotherapy is always better. It is always said that never combine A with A, that is ACE inhibitor and ARB should not be combined. You can combine ACE inhibitor with diuretic, ACE inhibitor with CCB. ACE inhibitor can be combined also with, usually it is not combined with beta blocker, not usually by and large not combined with beta blocker. While diuretic you can combine with CCB, you can combine with ACE inhibitor, you can combine with ARB. You can see a beta blocker. Beta blocker is in one corner. You can combine dotted line with diuretics. But by and large, beta blocker is not combined with other as a drug of choice. But it can be add-on therapy with other, and particularly in a person with ischemic heart disease, acute MI, congestive heart failure, post-MI, etc. Beta blocker, unstable angina, stable angina, beta blocker becomes a drug of choice. So go through this slide at your leisure time. Again, ACE inhibitor and ARB should not be combined. Always remember. So this is that same. A can be combined with D, A can be combined with C, C, B is separate. So it can combine with both this. C can be combined with D, C can be combined with A. So that possibility is always there. And beta blocker is indicated in angina, post-MI, heart failure, atrial fibrillation, aortic aneurysm, etc. We have done in detail. So these are all possible combination which are recommended. 2 drugs combination. These are 3 drug combination. We call it A, C and D. See, B is not there. Here also B is not there common. B is very rarely combined with CCB. But B is not a common combination, and beta blocker should not be, no combination, by and large should not be combined with diuretic except in a case of a heart failure. By and large, these two drugs should not be combined, ACE inhibitor and ARB. And you should not combine ACE inhibitor or ARB with what we call as a renin inhibitors. Renin inhibitors. You should not combine with those groups. So these are all those dual combination, triple combination which are available in markets. Go through your at leisure times. And these are never combined. And these are some of the drugs which you utilize and don't utilize in pregnancy. Selective. So safe drug during pregnancy, hydralazine, methyl dopa, labetalol, etc. and calcium channel blocker. Avoid diuretics, propranolol, ACE inhibitor and sodium nitroprusside. This should be avoided. And these are never combined. We have already mentioned before. And some of the other combination which should be avoided. Go at your leisure time. These are all what we call as drugs which are of choice during pregnancy: methyl dopa, labetalol, nifedipine and hydralazine. These are the drugs, and these are the adverse side effects. Because of the adverse side effect, methyl dopa is outdated. Labetalol and nifedipine is a drug of choice. These are what we call is a follow-up. In a follow-up, regular blood pressure checkup, weight control, have a checkup for sensation because of diabetes, HbA1c, triglyceride, cholesterol, LDL, HDL, lipid profiles, eye checkup, all this should be done. And this is what we call as sequential follow-up, what should be done. And if you don't do this, you will miss good number of time. Mask hypertension, mask uncontrolled hypertension, etc. Resistant hypertension, pseudo-resistant hypertension you will make out, and you will treat with the wrong drugs. Now we go to the step second. That is what we call as after treatment. Suppose BP is controlled. You have to have a regular follow-up. But say BP monitoring you are doing and it is uncontrolled. What you do? First, always rule out that person is taking salt restriction, reduce stress, stop NSAID, steroids, oral contraceptive pills. This is a must. And after all this, if still it is uncontrolled, add antihypertensive drugs. Now in an antihypertensive drugs, look at whether person is adherent or is changing the dose. Is he taking a proper dose? Have you given a proper dose? Have you used a proper combination? We have already shown you the slides of proper combination. Use all those possible things. And after these two things, now only you can add additional. Have a proper blood pressure monitoring, like ambulatory blood pressure monitoring. Rule out labile, rule out mass, white coat, resistant hypertension, etc. And then do investigation for primary and secondary. Rule out secondary cause. These are all the things which interferes with what we call as a BP control. So again, salt, stress, NSAID, steroid and oral contraceptive pills. Look at the dose properly. Look at the person is compliant or not. Look at the proper combination you have used or not. You have used the proper dose, not. With an ambulatory blood pressure monitoring, find out whether it is labile, mass, white coat or resistant hypertension. By investigation, again re-investigate and find out whether it is secondary or not. And then what we say that add on fourth drug, fifth drugs, sixth drugs, etc. Or you might go for renal denervation and treatment for secondary. And in case of secondary, some causes are reversible, which needs surgical intervention, so that can be done. So that is this what we have uttered before. Try to identify it belongs to which group, whether it is control or not, controlled resistant hypertension, controlled hypertension, whether it is a refractory resistant hypertension or uncontrolled hypertension. Try to identify, go on stepping up the dose, go up to the fifth dose, and if blood pressure is controlled less than 140/90, maintain it, have a regular follow. This is for secondary hypertension, how you approach and what are they. You can undergo and you can look at this slide at your leisure time. Just I am putting this particular, any person who develops sudden shoot up of blood pressure, severe elevation of blood pressure, person is having labile hypertension, person who is regularly following your advice, is taking all precaution to prevent resistant hypertension and to prevent pseudo resistant hypertension, still he is hypertensive. There is a refractory hypertension, person is complaining of severe headache, very young individual, say a person is of a 20-25 years age, person is having palpitation, diaphoresis, serum creatinine is gradually getting elevated, person is having symptom signs of endocrine symptomatology, clinically the person is obese, there are stria, hirsutism, etc. There is a clinical evidence of metabolic syndromes, or person is having obstructive sleep apnea, rule out secondary cause. And in this group, if you treat that basic etiology, it may be reversible. And this is that particular flow charts. Again, at your leisure time, go through. These are all the investigation which you can do, which are usually not done in a while identifying primary. We will have to do blood urea serum creatinine, go for KUB, IV urography. If creatinine is more than 3, don't go for IVU or IVP. Renal angiography, CT angio, MRI angio, again precaution if the creatinine is more than 2.5 to 3. They say, some people say even 2, don't try to do this. So there will be some restriction while doing renal angio, CT angio or MRI angio or IV urography. These are all where you use a dye, and person can develop a dye induced acute kidney damage, AKI. You can go for a Doppler duplex and try to identify if there is any renal involvement or any abnormality in an adrenal gland. Do a renin level, do a captopril renography. You can go for renal vein renin ratio. It is called RVR ratio. All these are the diagnosis or disease you are suspecting clinically, and they are the diagnostic test. Have a pause, go through your leisure time. And treatment wise, yes, TLC is necessary in all the cases, whether it is primary or secondary. You used A, C, D and B. You use centrally acting drugs. Still it is not coming under control, and if the person has got secondary etiology, treat the basic cause. Usually renal artery stenosis can be treated by stenting. If a person is having a odd etiology, you can have a carotid baroreceptor stimulation by what we call as a, there is an instrument called as a carotid baroreceptor stimulators. In a case of a resistance or uncontrolled hypertension, you can go for renal denervation. This is somewhat like the pacemaker, and it stimulates the carotid baroreceptors. It is, like a deep brain stimulators. There is a pacemaker like instrument which stimulates a carotid baroreceptor, because one point is given at the carotid baroreceptors, and that can be helpful in some person, not in all. Renal replacement therapy, or we call renal transplant, in a person with an end-stage renal disease. This is a diagram which is showing you. You can see that you can introduce an instrument and you can undergo what we call as a renal denervation. So this is a renal denervation which is being done. Here, in a renal artery stenosis, you introduce an instrument, dilate and put a stent. This is atheroembolization. You remove the embolus and you dilate this particular stenotic part and put a stent. While here you put a wire, this probe, and you burned out all those sympathetic fiber which are supplying this renal artery, and that's why it is called renal denervation. It is a denervating of a sympathetic fibers. So you burn out those particular fiber by a radio frequency. Now, if a person comes with a hypertensive emergency, like systolic blood pressure 180, diastolic 110, and he is having either urgency or emergency, Urgency, you can go for oral drugs, but if in case of a doubt, use injectable. But in case of emergency, it is only parenteral. And I've already told you, in parenteral, you will have to use certain drugs, particularly what we call as IV, hydralazine, or you can go for nitroprusside. Nitroprusside is outdated. Now they use most commonly is NG, we call as a nitroglycerin. So most common drug utilized is nitroglycerin, and second common drug is hydralazine. So that is being utilized. So if a person is having end organ damage, hypertensive encephalopathy, subarachnoid hemorrhage, intracranial hemorrhage, acute pulmonary edema, AKI, dissecting aneurysm, unstable angina, acute MI, in all these conditions, or in a person with a severe eclampsia, you will have to treat as an hypertensive emergency. So that is hypertensive emergency. Even they add accelerated hypertension, malignant hypertension, or they combine these. This terminology is now almost gone. Accelerated malignant hypertension, that is gone. And these are the different conditions. What are the drug of choice? See, nitroglycerin, nitroprusside, nitroglycerin, nitroprusside. And in some, labetalol, nicardipine. So depending upon what is the emergency, what is the complications, you can use. And these drugs are contraindicated. Try to go through that at leisure time. This is same first line alternative drug of choice. These are how you give, what is the side effects, what special indications where you can use the drug wise. Sodium nitroprusside, nicardipine, the what we call the calcium channel blocker, then phenylnipropyl, nitroglycerin, enalapril, or hydralazine. The commonest drug utilized is hydralazine, nitroglycerin. These are the two commonest drugs, and then comes sodium nitroprusside. These are the three common drugs which are most commonly utilized. Labetalol is another drug which is available as a beta blocker, which is utilized in hypertensive emergency. Rarely they utilize esmolol and pentolamine. Pentolamine is a drug of choice in a person who is having pheochromocytoma. Now, these are the things. Guidelines are evidence-based. Yes, evidence-based, you cannot ignore them. They should be utilized. There are a lot of guidelines, and every year some new guidelines comes. Meaning, still we are not sure what is beneficial, what is dangerous. So what is the take-home points? Guidelines are meant for guidance, but it is not mandatory. If I purchase one shoes, it does not fit everyone. So as a shoes does not fit, this coat also does not fit, this also does not fit. So one size does not fit all. So one size fits most? No, definitely not. Does not fit all. So what should be there? New hypertensive guidelines, one size fit most? 100% no. So most important part, lower the blood pressure, lower your risk. What is that? Lower below 140/90, and depending upon the compelling indication, lower it to 130/80, 120/80. Treat the patient and not the number, and try to reduce the risk as much as possible. And this will help you in reducing the mortality and morbidity. Now, I have kept 4 or 5 different cases. Go through your leisure time, read properly, make the diagnosis, write down the management, and communicate with me. Okay, so this is case number 1. This is case number 2. I have labeled as case 1A. This is a separate case. This is a third case. What is the possibility? What you will do? Try to answer. Write down separately and give me that answer. This is 2A. What is the possibility? What you will do? What is the diagnosis? What are the further investigation you will go for? This is last case. So goodbye. I think this will be helpful to you, and I'll see you soon. and I think it will be helpful to all interns and all who are practicing.